All right. So we should be live now. So come on in, everybody. Good evening or good afternoon, depending on where you're joining us from. Thanks for being here tonight. Today, we are going to be discussing interpreting biopsy results. So we have the lovely Dr. Pei-Ling Chen joining us today. Thank you so much, Dr. Chen, for being here with us.
Pleasure.
Dr. Chen is an assistant member in the Department of Pathology and Cutaneous Oncology at Moffitt Cancer Center. Her clinical practice is in dermatopathology, and her research work is primarily focused in cutaneous T-cell lymphoma. So we're going to dive right in here. Just a quick note of housekeeping. If you do have any questions, there's a little icon at the bottom of your screen that says Q&A. You can feel free to type them into us, and we will try to get to them as time allows. And just once again, thank you to our corporate partners and their individual donors. We certainly couldn't do these programs without you. So I'm going to turn things over to you, Dr. Chen. Thank you so much for joining us.
Thank you. So today, my presentation will be on cutaneous T-cell lymphoma biopsy result. So I'm an assistant member at Moffitt Cancer Center, practicing dermatopathology. So this is the overview of my presentation. I will first go over a simple slide on WHO classifications of cutaneous T-cell lymphoma, CTCL. Then I will talk about mycosis fungoides, which is the most prevalent form of CTCL, its epidemiology, clinical manifestations, as well as the need for skin biopsy for histologic evaluation. Then ending with mycosis fungoides pathology and ancillary workup with sample pathology reporting. So cutaneous T-cell lymphoma, this is a cancer of skin homing T cells. So normally a function of a normal T cell is usually to attack outside pathogens and cancer cells. But in this case, the cancer cell itself is the T cells. So it's a skin homing T cell. It develops in the skin and can progress to involve lymph nodes, blood, and visceral organs at advanced stages. So here we're looking at a scanning micrograph of electron micrograph of a T cell. So two main forms of CTCL, mycosis fungoides, MF, it comprises approximately 50 to 70% of CTCL, most commonly CD4 positive T cells. And Sézary syndrome is also another main form of CTCL. It comprises approximately 1 to 3% of CTCL, is the leukemic variant. So here we're looking at 2018 update of WHO EORTC classification for cutaneous T-cell lymphoma. As we can see here, this is a very heterogeneous group of cutaneous T-cell lymphoma, T-cell lymphomas. So mycosis fungoides, as I said, is the most common form, the most prevalent form. Sézary syndrome is a leukemic variant of CTCL. We also have primary cutaneous CD30 positive lymphoproliferative disorders, cutaneous adult T-cell leukemia lymphoma, subcutaneous paniculitis like T-cell lymphoma, EBV-associated lymphoma, extranodal NK T-cell lymphoma nasal type, as well as a few primary cutaneous peripheral T-cell lymphomas. This is a very heterogeneous and diverse group of T-cell malignancies involving the skin. So here we're looking at a pie chart of relative frequency of CTCL. As I previously mentioned, you can see mycosis fungoides is the most prevalent form. So mycosis fungoides, it is a rare cancer. It occurs in approximately 1 in 100,000 to 350,000 individuals. In the US, we see approximately 3.6 cases per million people each year. It affects patients of any age. Average is 55 to 60 years old. Higher incidence is seen in males than females. The ratio is approximately 2 to 1. The overall incidence rate for CTCL is higher in Blacks than whites and other racial groups. It is also thought to follow a more aggressive clinical course in Black populations with higher cutaneous disease burden and inferior survival. So skin manifestations of CTCL, there are three main forms. Actually, three main forms for mycosis fungoides: patch, plaque, and tumors. Nodal disease, involvement of lymph node, can occur late in the disease course. It takes average of 4 to 6 years from the onset of skin lesions to formal diagnosis of MF. Sometimes it can take decades and often require many biopsies to confirm the diagnosis. This can be a very long, protracted course and can be very frustrating for the patient since a lot of biopsies are needed to confirm. So I think both the patients and the clinicians need to understand and be patient with this process. The symptoms and skin biopsy finding of MF can be very, very similar to other benign skin conditions. This is why the diagnosis is challenging both clinically and histopathologically. Clinically, it can look like, I will show you clinical photographs, as well as pathology slides. So clinically, it can look like eczema, psoriasis, drug eruptions, and a variety of other inflammatory skin dermatoses. Patient may go for years or even decades before definitive diagnosis of MF is established histopathologically. At the present time, there's no known cure for MF. Some patients have long-term remission with treatment, many with minimal or no symptoms for many, many years, and some progress to or present with advanced stage disease that's refractory to multiple forms of systemic therapy. So the clinical course is heterogeneous as well. So next on to clinical manifestations of mycosis fungoides. So here, as I mentioned, the three main clinical manifestations are patch, plaque, and tumor. So here we're looking at a patch lesion of mycosis fungoides. We see at this stage, you see mostly flat, slightly wrinkled lesion with fine scale, and they typically happen in some protected sites. And then we're looking at the plaque lesion. So these are, compared to the patch lesion, these are usually thicker, raised, and still relatively scaly skin lesions. And this, we're looking at a tumor lesion. So these tumors are usually raised bumps or nodules, which may or may not ulcerate. So here we're looking at tumor lesions here. Tumor lesion can develop after years of patch plaque lesion as they progress from patch plaque lesion to these tumors, or they can arise de novo, meaning the patient present without a long protracted course of mycosis fungoides patch plaque, and they just present directly with tumors. This can happen as well. So patch plaque tumor, it is possible to have all three types of lesion at the same time. And lastly, as I said, besides patch plaque and tumor, the Sézary syndrome, which is a leukemic variant where you have leukemic variant, meaning the blood involvement of cutaneous T-cell lymphoma cells. You have these Sézary cells circulating in the blood, and what you see on the skin is this total body erythroderma, or basically redness. So MF staging, clinical staging for mycosis fungoides is dependent on clinical presentation and histopathologic evaluation. In essence, what you have is T stage, which is tumor. For T1 lesion, these are patch plaques occupying less than 10% of body surface area. T2 is more widespread skin involvement. You see patch plaque lesions involving greater than 10% of body surface area. T3, you start seeing is defined by tumor lesions. T4 is erythroderma, or involving greater than 80% of body surface area. We also, besides T stage, we also examine lymph node, distal site involvement, as well as blood involvement to derive at the final clinical stage for MF. And anything from T3 or beyond, 2B, clinical stage 2B to 4B, and histological stage T3 beyond is considered advanced stage MF. So since histologic evaluation of these cutaneous lesions is important to for staging and for diagnosis, I will next go over what happens when a patient gets a skin biopsy. So two main forms of biopsies performed by dermatologists are shave biopsy and punch biopsies. So for patients who have suspect to have MF, or they're probably fairly familiar with, they go through a lot of biopsies over years, so they're probably fairly familiar with this. So this is, we're looking at a shave biopsy. What we do, the dermatologists, they take a tool, or clinicians take a tool that is similar to a razor, and they remove a small section of the top layer of the skin, which includes the epidermis and portion of the dermis. So this is a shave, a more superficial biopsy, a broader surface area. Punch biopsy here, we're looking at, you take a circular tool and you basically drill into the skin to remove a small core of skin. And because this is a deeper biopsy, you would get epidermis, dermis, usually pretty much the full dermis, as well as some superficial fat. This is to examine for lesions that involve deeper into the skin. So this is a punch biopsy. So what happens after, so for patients with MF, they will get a shave biopsy for the patch black lesions and punch biopsy for if it's tumor or something that involves deeper skin. So what happens to these biopsies after they're taken? So here we're looking at the tissue that are taken out by punch biopsy. So to examine for the histopathology, we usually put them in these formalin bottles and send to pathology for tissue processing. So this is one way for FFPE base, so we can generate slides for histologic diagnosis. Alternatively, at Moffitt, we also send fresh tissue from select patients, depending on clinical need, for flow cytometry, where we look for cell surface marker expression. So that requires fresh tissue. So this can go to either formalin bottles for FFPE-based histologic diagnosis or fresh tissue for flow. And for the specimen, since I'm a pathologist, I will go over a few slides of what happens to these tissue in our pathology lab. So after the specimen is delivered to pathology lab, day one, we have someone who grows the specimen, meaning they will take this shave or punch, examine it, evaluate it, document the size. Is there anything they see on the skin? And they, basically cut these tissue into pieces. For shave biopsy, depending on the size of the shave, it can be bisected, trisected. For punch biopsies, we usually bisect them in half. So they examine this, usually a grows from PA, resident fellow, they process these tissue, put them into cassettes. Then they would sit through our histolab tissue processor for embedding, staining, put them in blocks, and processing for it into these blocks, so they can cut these embedded tissues onto slides for pathologists to evaluate on under microscope. So here we're looking at shave biopsy, 3 pieces at day 3, usually day 3, and this is a punch biopsy. So if a pathologist determines that there's enough lymphoid infiltrate for further workup, we usually order, for mycosis fungoides, we typically order at least a certain number of immunohistochemical markers to derive a diagnosis. So this is an example of IHC slide. And oftentimes we also perform molecular studies from these tissues. You cut slides from these and send for molecular testing, such as T-cell receptor gene rearrangement studies, to identify the monoclonal malignant T-cell, if there's monoclonal malignant T-cell population. So this is quite a few days from here, day 3. From here on is day 4 plus for the full diagnosis to be rendered. So what happens after the slide sits in the pathologist's office and after the full workup? So here, my final section will be on MF pathology and ancillary workup with sample pathology reporting. So as I mentioned, MF is very difficult to diagnose, especially in early stages. It takes a long period of clinical evolution. It has a long period of clinical evolution. So the disease itself sometimes take many years, up to a decade to evolve. Treatment also alters pathology. When you put on steroid, you can't actually mitigate the histologic findings. Diagnostic criteria in early lesions can be very subjective. There are a lot of pathologic mimickers as well. So these are the challenges. So here we're looking at the patch lesion, MF patch lesion. So as I said, it's difficult to diagnose because of overlap with other inflammatory disorders. Just looking at this could be eczema, could be drug eruption. It's difficult to tell. So usually dermatologists will biopsy these lesions to see what they look like under the microscope. Under the microscope for this lesion, what we see here is, so we're looking at the epidermis here, top of the skin, dermis, and there's some dermal blood vessels. These are the blood vessels. In this case, what we see is malignant T cells circulating, circling the blood vessels, and then they can go into the epidermis. This is called epidermal tropism. At higher power, this is the patch lesion onto slide. So at higher power, this is another patch lesion. You see patchy upper dermal, this is the upper dermis. Lymphohistiocytic infiltrate, so these are the lymphocytes, the T cells, malignant T cells surrounding the blood vessels. You can see this is a comparison. Normal skin usually does not have a whole lot of lymphocytic infiltrate. If you have lymphocytic infiltrate, it could be an inflammatory benign skin condition versus mycosis fungoides, which this is the malignant version. So in this case, this is a malignant patch plaque lesion. You see the malignant T cells circling around the blood vessels. We call this perivascular lymphocytic infiltrate. And then some go into the epidermis, and that's what we call epidermal tropism. A lot of times, one of the features of mycosis fungoides is what we call fettuccine sign, papillary dermal fibrosis. This is the papillary dermis layer of the skin. So you see some fibrosis with malignant T cells infiltrating these fibrotic bands areas, and that's what we call fettuccine sign. And the malignant T cells that goes into the epidermis, that's what we term epidermal tropism. Usually, besides these kind of low to mid power evaluation of the skin, I also look at high power for cytologic atypia, meaning are these lymphocytes, do they look at high power? The shape, the size, the features, are they different from a normal T cell? So here at higher power, I can see in this epidermis, I see a aggregate of malignant T cells. And what we call this is like a little abscess. We call this Potrier-like microabscesses of malignant T cells here. And they can home to the epidermis, the skin. Other findings, you see malignant T cells. Again, this is the epidermis, the keratinocytes. This is the dermis. You can see the malignant T cells tagging at the dermal-epidermal junction, what we call Toy soldier. So this is another finding of mycosis fungoides. Higher power, we see these are, again, malignant T cells, perinuclear halo, these ring of emptiness around the nuclei. Perinuclear halo is another sign. And if you look at these malignant T cells, instead of like a very kosher, benign, small looking T cell, you see these are irregularly shaped, kind of spindled. You don't see a smooth border, hyperchromatic nuclei. So these are features that I look at that I consider as cytologic atypia. And we call these cerebriform lymphocytes because they look kind of like the brain. So even though it seems simple, straightforward, we have diagnostic criteria running through, the lymphohistiocytic infiltrate, papillary dermal fibrosis, epidermal tropism, cytologic atypia. Even though this seems Potrier microabscesses, even though these seem like very obvious findings that we can easily diagnose, is actually not true. Because similar features can be seen in benign skin lesions as well. So here we're looking at a cutaneous T-cell lymphoma. Here we're looking at an eczema. You see there's more spongiosis, meaning like emptiness between gaps between the keratinocytes. But again, both cases, you will see some lymphocytes in the epidermis, going into the epidermis. In this case, I would call it epidermal tropism. In this case, I would call it exocytosis. Usually, I would see more cytologic atypia in CTCL. I do look for those. But it's not a guarantee. Sometimes, these can have some irregularities as well. So it's tricky by H&E. But the obvious cases, you will see the findings that I mentioned. So because this is a challenging diagnosis, we usually, for mycosis fungoides, histologic evaluation usually involves quite a few ancillary studies and workup. So immunohistochemistry is a very important ancillary study for MF workup. The classic MFKs are usually CD4 positive malignant T cells. So these are CD3 is a T cell lineage marker. I usually order that in my evaluation. At least make sure these lymphocytes are T cells, not a B cell. So B cells would be, for pathologists, we would see, CD19, PAX5 staining. But if I want to call something a cutaneous T cell lymphoma, I want to see those cells are CD3 positive. And there's difference because even though majority of CTCL is CD4 positive T cell lymphoma, there are some CD8 positive mycosis fungoides or cutaneous T cell lymphoma that behave slightly differently from a CD4. So I always order CD3, CD4, CD8, as well as a few other T cell lineage markers for the workup. So a classic CD4 positive MF, I would see a CD3 positive malignant T cell, which is a T cell lineage marker that is CD4 positive as well, but with a CD4 to CD8 ratio of greater than 4 to 5 to 1. So I want to see this ratio to be skewed. whereas normally a non-malignant ratio typically is 1.5 to 2.5. This is not a hard fast rule, but for a perfectly fit MF case, I do like to see a skewed ratio. So even though the classic form is CD4 positive mycosis fungoides, the malignant MF can also be dual CD4, CD8 positive, or as I mentioned, we also have variants that are CD8 positive, CTCL. These mycosis fungoides can show variable loss of CD2, 5, and or CD7. It can be variable, but seeing loss of these markers is helpful for the diagnosis. Besides immunohistochemistry, we also perform molecular testing, looking for clonality of T cell gene rearrangement. So we would hope that the malignant T cells are clonal and demonstrate a clonal peak. So this is an indication that this is more likely to be a malignant process, but false positives can occur. What we like to see is what is especially helpful is if we can find the same clone in separate lesions and separate over time. That's actually very indicative of a malignant T cell clone. So again, so as I showed you previously was an H&E. So this is an H&E slide, H&E based histologic diagnosis, skin epidermis, dermis. We have these blood vessels in dermis, malignant T cells surrounding these blood vessels and going into the epidermis. We also see epidermal tropism. These are clusters of malignant T cells, what we call the Paltrioli microabscesses. So this is a pretty classic histologic image of mycosis fungoides. So when we do immunohistochemical workup, so we can see the CD4 to CD8 ratio is completely skewed. We see a lot more CD4 positive T cells that do not express CD8. So this is actually, immunohistochemically very fit for a mycosis fungoides patch black lesion. So besides immunohistochemistry, we also do other workup to help to enhance our diagnosis, especially T cell receptor gene rearrangement. This is the clonal peak I previously mentioned. So essentially we send these tissue, grant their DNA, look for malignant T cell clones. So these peak will be a dominant clonal peak, suggesting this is a monoclonal population of malignant T cell. So this helps our diagnosis, but it can be deceiving because benign inflammatory dermatologic conditions, such as pityriasis lichenoides, they can have these dominant clonal peaks as well. So it's not 100% accurate, but it helps. All these pictures taken together from H&E, immunohistochemistry, TCR gene rearrangement, correlating with clinical presentation, helps us derive at a diagnosis. And sometimes this process takes time. So besides TCR clonality study, we also do flow cytometry in skin and blood. Not on every patient, but sometimes when the clinicians feel that it will help their diagnosis, they will send it. So this is our skin biopsy CTCL panel. This is a more comprehensive. Usually we do that in blood to evaluate for T cell subsets. So what we examine for is the cell surface marker expression to suggest whether we see malignant T cells in these biopsies. So in summary, histologic diagnosis of early mycosis fungoides is very hard, very challenging. We need clinical presentation, histopathology, and ancillary workup. Clinical presentation, when I make a diagnosis of MF on pathology, I always check the clinical history. I would like to see some chronicity. I mean, ideally, I would like to see some chronicity, though, as I mentioned, some of these lesions can, the early lesions, there's not much chronicity. It may be the first sign of MF, or even tumors can present de novo. If a lesion is waxing and waning, I may not think of mycosis fungoides. I would think of some entities such as lymphomatoid papulosis, LYP. If a lesion is completely gone, never comes back, I hesitate diagnosing MF as well. So my histologic diagnosis has to fit the clinical presentation. I also look for, so histopathology is very important, is the key to diagnosis. All the features I mentioned in the previous slides, perivascular lymphocytic infiltrate, epidermal tropism, papillary dermal fibrosis, cytologic atypia, lymphocyte tagging a dermal epidermal junction, all these together give me a picture of what I think is this histopathologically fit to call it MF. I also perform immunohistochemistry. As I mentioned, the CD4 to CD8 ratio. Is there a loss of CD7 or other T cell lineage markers? So that's one thing. TCR clonality, as I mentioned, best if the same clone across space and time. And sometimes we supplement by flow cytometry in both blood and tissue. So this is a lot of workup, and the pictures may not always add up. For example, you can have histopathology that looks really very much like MF, clinically doesn't fit, IHC doesn't fit, TCR also doesn't fit, then we back off. And I would probably say, I would let my clinician know it's suspicious for, but not diagnostic of. So it's a lot of consideration, and this is why the diagnosis of mycosis fungoides takes time, patience, and also we don't want to overcall, and at the same time, we don't want to undercall as well. So despite the best interest and effort, there is still 40%, despite all these workup, there is still a high false negative rate, high false positive rate, as well as inter-observer variation. Bottom line is, if truly MF, it will evolve. We will see it. It takes a little bit patience for the clinicians, the patients, the pathologists, to put together a sound clinical pathological correlation to reach at the final diagnosis. And someone once said the best way to rule out MF is to make another diagnosis. But essentially, for a true MF case, we would hope that it will evolve and reveal itself over these biopsies over time. So diagnostic criteria, the International Society for Cutaneous Lymphoma did attempt to put a table together with some point scoring system to help guide our diagnosis of MF. But as I said, this is very helpful. It gives us some roadmap to derive at that diagnosis, but it's not perfect every time. A lot of these cases are very challenging. You may have 2 points here, no points there, but clinically it looks so much like MF. So it's still bottom line is you need clinical pathologic correlation. So here's a sample pathology report. So this is a flank biopsy. And what we see here, so this is the epidermis, the dermis, dermal blood vessels, perivascular malignant T cells, and epidermal tropism, meaning these malignant T cells home to the epidermis. So in my comments, I would say sections of these skin shaped sections show an atypical lymphoid infiltrate in dermis with prominent epidermal tropism. The atypical lymphocytes, I talk about cell size for a reason I will explain in the subsequent slides. The atypical lymphocytes are predominantly perivascular and dermal interstitial distribution with associated papillary dermal fibrosis, the fibrotic bands. The atypical lymphocytes, I talk about size, small to medium in size with hyperchromatic nuclei and irregular nuclear contours. This tells my clinician I see the low power and high power features of mycosis fungoides, both in terms of the distribution and as well as the cytology. Then I perform immunohistochemical workup. So this is an example of a pathology report. I say immunohistochemical studies were performed to further evaluate the atypical lymphoid infiltrate and show a predominance of CD2+, CD3 positive, CD5 positive T cells with a CD4 to CD8 ratio of greater than 6:1. Ideally, I like to see over 4 to 5. So this is basically a perfect case of MF. So it's a greater than 6:1 in the epidermis and dermis. There's loss of CD7 expression. As I mentioned, I do want to see some loss of T cell markers. That is helpful to see some loss of T cell markers. I also check for B cell markers, CD20, to make sure this is not like a B cell process. So CD20 immunostain highlights rare B cells. CD30 immunostain we always perform because brentuximab is a treatment for CTCL, and that's an anti-CD30 antibody. So we want to see stain for CD30 for its expression, document what percentage of the lymphocytes express CD30. And for this case, if I perform molecular studies, I would say molecular studies for T cell receptor gene arrangement were performed and demonstrate monoclonal beta and gamma chain rearrangement. So summary taken together, the histologic features and immunohistochemical profile are consistent with mycosis fungoides patch plaque lesion. So I bottom line this case is usually a pathology report has a final diagnosis bottom line. Here I write atypical lymphoid infiltrate dermis with epidermal tropism consistent with mycosis fungoides patch plaque lesion. And see comment, this is a comment. I went through the comment with you first. So this is sample pathology reporting number 1. Next report. So this case is less obvious compared to the previous one, as you can see in the previous slide. You see a lot more these atypical lymphocytes, in going to the epidermis, around the blood vessel, just basically busier. Here we're seeing a more subtle atypical lymphoid infiltrate. Again, the epidermis, the dermis. There's some dermal blood vessels here, but the perivascular lymphocytes are a little more milder compared to the previous one. There's also some exocytosis of lymphocytes into the epidermis. So I describe basically what I see under the microscope. So in my comment, I would put section show an atypical lymphoid infiltrate in dermis with focal exocytosis. In this case, I'm not so sure if this is mycosis fungoides. So instead of saying epidermal tropism, I call this exocytosis going into the epidermis. The atypical lymphocytes are predominantly perivascular in distribution. With associated, there's also papillary dermal fibrosis, which can see in some chronic inflammatory process as skin inflammatory process. So the atypical lymphocytes show mild cytologic atypia in this case. They're not as cytologically atypical as the previous slide I show you. So mild cytologic atypia, some with hyperchromatic nuclei, some with irregular nuclear contours. So basically I'm telling my clinician, I do see some irregular features, but it's not a classic perfect case. So I perform immunohistochemical studies to evaluate the atypical lymphoid infiltrate. Here, I still see a predominance of CD2 plus, CD3 positive, CD5 positive T cell. And in this case, the CD4 to CD8 ratio is not so skewed. So in this case, we see a ratio of approximately 2 to 3 to 1. As I mentioned previously, I do like to see a more striking 4 to 8 ratio is more fit for mycosis fungoides CTCL. It doesn't mean that a lower ratio is not. It could still be, but I'm basically just saying it's not perfect, but we cannot rule it out. So here in this case, the CD4 to 8 ratio is approximately 2 to 3 to 1 in the epidermis and dermis, meaning epidermis meaning the exocytosis cytotic lymphocytes, as well as these perivascular lymphocytes in the dermis. Again, I report there's partial loss of CD7 expression, not all the lymphocytes lost CD7 expression. I also document if I see any CD20 positive B cells, what is the CD30 distribution expression like? In this case, I perform molecular studies for T cell gene rearrangement because I wasn't so sure, especially if there's a high clinical suspicion, I don't feel like I'm fully achieving a CTCL/MF diagnosis. I would add molecular studies to see if I could get a little more information. In this case, because the lymphoid infiltrate was sparse, there's not as much. So the molecular study for T cell rearrangement shows DNA insufficient for testing. So taken together, I didn't feel a very strong inclination to call this mycosis fungoides or CTCL. I would say taken together, the histologic features and immunohistochemical profile are not diagnostic for involvement by a cutaneous T cell lymphoproliferative disorder. And based on the histologic features, I would give also the clinician some non-malignant T cell process as well. So in this case, differential diagnosis includes drug eruption, urticaria, viral exanthem, and I say clinical pathological correlation is recommended. For these cases followed at Moffitt, that are closely followed, I always put a disclaimer. If there's strong clinical suspicion, as T cell lymphoproliferative disorder can develop over time, close clinical monitoring and sampling over time and additional sampling over time is recommended. This type of scenario is kind of why multiple biopsies over time is helpful. Sometimes even if we get a clonal TCR population, if the histology is very subtle, I also may not want to call this straight, give a cancer diagnosis when it's not. That would be overcalling. So the subsequent biopsy, I could do the same exercise in the subsequent biopsy. I can identify the same TCR. For example, if this case were TCR positive, if I could find the same TCR clone in biopsies over time, I would feel more comfortable that this is more suggestive of cutaneous T-cell lymphoma / mycosis fungoides. So as you can see, histologic diagnosis for early mycosis fungoides is very challenging. Clinically, it mimics other benign skin entities. Histologically, sometimes it's also not very clear cut. It requires, I feel like I'm nailing the same message, long course of many biopsies and patients from both the patients and also the treating clinician. Once we reach the tumor stage, the diagnosis is much more clear cut. So here's a tumor lesion. Just looking at very low power, I see a skin biopsy here, epidermis, dermis. I see this dermis, we call this pandermal atypical lymphoid infiltrate. This skin is basically filled with malignant T cells here. Pandermal meaning the entire dermis is involved by atypical / malignant lymphocytes. At this stage, the epidermal tropism is frequently absent. In de novo lesions, so without the epidermal tropism, if a patient does not have a long-term course of patch plaque lesion, the pathologist also needs to be careful because in these de novo, meaning newly arised tumor without previous patch plaque, we need to be careful it's not as cutaneous involvement by other systemic T-cell lymphoma involving the skin. So there's a lot of, so usually we present these cases at tumor board, discuss with the clinician, make sure I also say, hey, there's no history of mycosis fungoides, no patch plaque lesion. I think this patient probably deserves a systemic workup as well to rule out other things. So we have, tumor board meetings to discuss cases. A lot of our tumor boards involve, is this MF or not? Like the previous case, is this benign or malignant? And then when we have these frankly malignant tumors, there's also a lot of clinical pathologic correlation, discussion with, dermatologists, hemoncs, radiologists, radoncs, to see is this MF tumor lesion or is this a systemic T-cell lymphoma? Should we check the lymph node, do other staging workup as well? So this is, even though histologically this is very obvious a malignant T-cell process, if it stains for CD3 T-cell markers, to us it's still challenging because we have to factor, could this be systemic involvement, cutaneous involvement by a systemic T-cell lymphoma? So this is a tumor lesion, deep infiltrated pandermal malignant T-cell involvement in the skin. In tumor lesions, sometimes we see what we call large cell transformation, which is a very aggressive form of cutaneous T-cell lymphoma. More frequently happens in tumor lesions, not patch plaque. We can see that in patch plaque lesions, but it's more commonly associated with tumor lesions. So here again, we have a pandermal malignant T-cell infiltrate filling the epidermis on histology. To diagnose something as these aggressive large cell transformed tumors, what we want to see is, compared to the small to medium-sized malignant T cells that I show you in the patch plaque lesions, what we want to see is these large blast-like malignant T cells that are 4 times the size of regular T cells. So for example, here, this could be a small T cell. At least 4 times the size of regular T cell. And we want to see these large blast-like cells, large cells comprising greater than 25% of the atypical lymphoid infiltrate. These large cells at higher power, you can see they often have the more pale, fine vesicular chromatin in the nucleus with prominent nucleoli. At this more aggressive stage, we can often see mitotic figures. These are the mitotic, suggesting this tumor is very highly proliferative, is actively proliferating. And sometimes we can even see necrosis, meaning tissue death, in very aggressive large cell transformed tumors. So sample pathology report for these lesions, for example, this case here, tumors. I would again make a comment to describe. Sections show a pandermal atypical lymphoid infiltrate in dermis with very focal epidermal tropism. The atypical lymphocytes are predominantly medium to large in size, with a mixed smaller atypical lymphocytes. The larger cells comprise greater than 25% of infiltrate, so this would set the criteria for large cell transformation. They appear immature and show vesicular chromatin and prominent nucleoli, while the mixed smaller lymphocytes show hyperchromatic nuclei and irregular nuclear contours. So I describe a large cell population and a smaller cell population. I also put into, based on what I see on microscope, I put a comment saying mitotic figures are readily identified. So the clinicians would have very good picture if they can see what I see under microscope. Immunohistochemical studies were performed to further evaluate the atypical lymphoid infiltrate, show a predominance of CD2 positive, 3 positive, 5 positive T cells with a CD4 to CD8 ratio. By this time, usually the ratio is fairly skewed, as in this case, greater than 8:1. There's loss of CD7 expression. Again, I typically stain a B cell marker CD20 just to make sure we're not dealing with a B cell lymphoma or some other strange process. Highlight scattered B cells. CD30 immunostain highlights approximately 10% of the lymphoid population. Molecular studies for T cell receptors. By this stage, we usually do not need the molecular TCR. It's probably fairly obvious this is a T cell lymphoma. But if we perform, it would demonstrate monoclonal beta and gamma chain rearrangement. So taken together, the histologic features and immunohistochemical profile are consistent with mycosis fungoides tumor lesion with large cell transformation. And this is what I bottom line flank. This should be punch biopsy, skin punch. Atypical lymphoid infiltrate dermis consistent with mycosis fungoides tumor lesion with large cell transformation. See comment. So this is a complete pathology report to my clinician. Alternatively, we can also have these tumor lesion, as in this case, without large cell transformation. So that's actually, usually the large cell transformed lesion get more aggressive treatment. And in this case here, tumor lesion, if I don't mention large cell transformation in the comment, it could be a very similar report, but I would say atypical lymphocytes are predominantly small to medium in size, show cytologic atypia. There are some scattered large cell, but comprising, for example, in this case, less than 5% of the infiltrate. In this sense, I'm telling the clinician hasn't made the criteria for large cell transformation yet. I performed the same immunohistochemical workup. You would see the skewed, positive a T cell marker. You would see the skewed 4:8 ratio, loss of CD7, molecular study doing arrangements demonstrating monoclonal malignant T cell population. So I bottom line this as mycosis fungoides tumor lesion. And I don't say anything about large cell transformation. They would know from this report, this is not large cell transformed. So these are, this is my presentation today, going from epidemiology of WHO classification, epidemiology of mycosis fungoides, clinical manifestation, how we process, how you get the skin biopsy, how they're processed in our histo lab, how we diagnose that on histology, and how pathologists issue reports to let our clinicians know what we see under a microscope. This way they can carry the next step into treatment based on this histopathology correlation, clinical histopathologic correlation. So thank you for giving me the opportunity to present today.
Thank you so much, Dr. Chen. That was like, I'm going to have to watch it like 3 more times again to really absorb everything.
For any pathologist.
Yes.
So this is our team. We have a multidisciplinary clinic, dermatology, hemonc, pathologist, electrophoresis center, hematopathologist, radiation oncologist, and this is our photo taken from one of the clinic days.
Thank you so much. It was super informative. And for those of you watching at home, if you're like me, you're going to need to rewatch it. So please know that we do post, it'll be posted within about a week of tonight. So if you'd like to go back and watch it again, you certainly can. Dr. Chen, we do have a couple of questions that were submitted ahead of time, if that's okay with you. And folks, if anybody in the audience has any questions, we can try to address them. And a lot of the ones that were submitted are actually sort of more around getting a biopsy done, if that's okay with you, Dr. Chen.
I will try my best.
Okay. Someone asked, will the biopsy hurt? That was the first question.
Usually you get local anesthetics.
Okay.
I have seen, so I've, from my fellowship training, we do have to do some biopsies, and I
Mhm.
do watch them um, from tissue-based research. So it looks like it will cause some discomfort, but they're actually under anesthesia. So maybe
Okay,
some
great.
pressure, but you won't get the drilling without any anesthesia.
Okay. So are they put under general anesthesia or is it just numbed? Local? Okay, so they'll still be awake. It would
Yes,
just,
they will wait for the anesthetics to take effect, so you won't.
okay.
It's
Okay,
kind of
great.
more blood pressure. And shave biopsy, you basically scoop it off, and there's no stitching. And punch biopsy, depending on the size of the punch, some may need stitching, some smaller ones may not.
Okay. Okay, let's see. Anesthesia was the next question. So you already answered that. Someone asked, will I have any scarring from the biopsy?
I think depending on how your body reacts to these biopsies too, some people don't tend to have scars and some people do. Usually shave biopsies, I would say very minimal.
Okay, so it probably also depends on the type of biopsy being done, I would guess.
Yes, and also I think some patients may be more prone to scarring and some not really.
Okay. Okay.
But regardless, I think if there's clinical suspicion for MF, this must be done.
Okay.
It's impossible to diagnose this entity without a biopsy.
Okay. Yeah, that was another question. Is there another way for me to be diagnosed without doing a biopsy?
It has to be, it's biopsy, but clinically, it could really mimic a lot of things.
Okay.
Eczema can look the same.
Mhm.
Usually the very, a widespread body involvement
Mhm.
is quite more suspicious for malignant process, but I have
Right.
seen in clinic, like drug eruptions can also have a very widespread patch plaque lesions as well.
Okay. Okay. Cool.
So it's pretty much needed for the diagnosis.
Okay. Thank you. Let's see. Will my biopsy be done in a hospital or can I get it done at my doctor's office?
You can get the biopsy done in dermatology clinics. They will send it for whoever they work with, the dermatopathologist or pathologist they work with, and it can be managed at a local dermatologist's office as well.
Okay. How long do I have to wait until I will get my results back?
Depending on what's done. So, hold on a second. So just the IHC, here, just the H&E onto H&E and IHC, we can probably get this within 3 to 4 days.
Okay.
If I want to add molecular, this can take another week.
Okay. So is it like sent out to a lab then? Is that how that works?
So some some dermpath labs, they have contracted labs that they send for TCR testing.
Okay.
At Moffitt, most of the hospitals, we will have our internal molecular testing capacity to run these.
Okay. Okay. And this is the last question for tonight. Am I restricted from my normal activity after my biopsy is done?
I don't think so. I mean, usually these are fairly small. I think shave, even the broadest shave I've seen is probably like maybe 1 centimeter.
Okay.
Punch biopsy can be 4 to 6 millimeter. So
Okay.
it's not going to restrict. But again, I mean, if your dermatologist or clinician is suspecting MF, regardless, you should get a biopsy.
Yeah.
And they will be the one deciding whether this is biopsy worthy or not.
Okay, great. Well, thank you so much, Dr. Chen. We really appreciate your time tonight. And
Thank you so much.
thank you for your expertise. And thanks for everybody joining us this evening. And just as a heads up, our registration for our upcoming virtual 2-day event is now active, and that is Friday, June 18th and Saturday, June 19th. So head to our website if you would like to join us. Thank you so much, everybody, and have a wonderful evening.
Bye.